Next question, review on sepsis coding. Could you all do a webinar on sepsis, severe sepsis with and without septic shock and SIRS? For example, if the patient has pneumococcal sepsis, sepsis due to a UTI, that type of thing, I think a refresher on the different types of sepsis and sepsis coding would be very beneficial. I would appreciate it very much. Well, we have done a lot of education on sepsis because it is an area that's confusing, not only to new coders, but to people that have been doing it for a while. Every once in a while, they make a little change, not a drastic change, but there's a lot of codes involved when you deal with sepsis. And the verbiage and the documentation is very long and drawn out. When you have sepsis, you're definitely going to be sent to the hospital. There is no getting over it without extreme treatment. I went to the CDC and I pulled out this first because we want to make it clear, what is sepsis? When a person goes septic or gets sepsis, it means the body is responding to an infection and it's more or less messing with its own tissues and organs. Some people may say, well, so-and-so's organs started shutting down. And that kind of could be a layman's term of saying a lot of times it happens to the kidneys. But ultimately, if not treated or even sometimes with treatment, things go downhill and the patients can succumb to sepsis. The CDC said at least 250,000 Americans die from sepsis each year. And that's significant. And how do they know that? Because of us coders that help them collect the statistics. So sepsis, per the CDC, is an infection acquired. It could be in a community setting or a healthcare facility. One of the things you'll notice when you look at the codes for sepsis, there's additional codes that they're going to ask you that if it's pertinent, how did the sepsis manifest itself? Was it due to a procedure that was done? Were they in a facility? And actually, the OBGYN sepsis can be due to birth, pregnancy, and abortion, whether it be a miscarriage or an elective abortion. That is statistically, and we're not talking just the United States, but worldwide, that is captured. And the CDC works off of the United States, but the World Health Organization, which I got some of this documentation from and footnoted it for you, is, again, statistics for the entire world. So sepsis is tracked across the globe. Whenever we are doing statistics for sepsis, it is something that facilities pay very close attention to because that is one of the places that people get septic infections. Just know that ultimately you can get sepsis and it be antibiotic resistant. That is another statistics that they track, is how often antibiotics are being prescribed. Are they being overprescribed? Is there a break period in antibiotics? Because we have become a world of being antibiotic resistant because of overuse. And it's a statistic that a lot of facilities will capture, and you as a coder may be auditing that or capturing that statistic for your facility. Whenever sepsis happens, it's life-threatening and can result in organ dysfunction. The words that you want to be familiar with, the verbiage, is septic, sepsis, septicemia, SIRS, septic shock, and always pay attention to multiple organ failure, which ultimately can be resulting in death. Those are the key terms that you're going to be looking for when you want to code and capture the codes out of the documentation abstract. Anytime you have an infectious pathogen, which there will be codes for identifying what infection, what bacteria, what is caused the sepsis. You can have antimicrobial resistant type of pathogens as well. Statistically, we need to know that. But sepsis patients, if they become resistant or are resistant, then you have a higher case of hospital mortality, and we don't want to see that. Scrolling on down, and those are straight from the World Health Organization. This is a great graphic that I think is very pertinent. This came from the CDC. If you understand the disease process where it works with sepsis, first of all, know that it's going to be some type of bacteria or infection that starts in the body. Okay, so the patient will be ill. Something has made them sick, and then sepsis takes over. And the 4 major ones to look for are something that happens in the lung, thus like pneumonia. 35% had a lung infection. They're saying these are common things that lead to sepsis. You had 25% had UTIs, some type of urinary tract infection. And if you've ever worked with an older population, a geriatric population, UTIs are a lot more common, and most of the time they have no signs and symptoms until they lose some type of a cognitive ability, and then they're taken to the ER, and sure enough, they've got a UTI. But if that's not treated because they don't have the signs and symptoms, then they can go septic. Then we go 11% had some type of gut infection, and you can see a whole list of types of problems that happen in the digestive tract. And then 11% also had a skin infection. Now, I have a son that he's pale, blue eyes, blonde hair, and it seems like no matter what happens, if he gets a scrape or a bug bite, he scratches it. And twice we've had to go into urgent care because the rash grew and started growing up his leg, or and big time scary, so we wanted to treat that aggressively. Skin, I think, is overlooked a lot of times, but that's like the biggest organ in your entire body. Know the signs and symptoms that sepsis is starting to happen. But now that you know lung, urinary, digestive tract, and the skin are your main ones, you'll notice that the codes are launched off from that. Go to the next page, and we'll look at something pertinent. A40 through A41. All of your A codes and a lot of your B codes are going to identify what the organism is. So, of course, A40 and A41, not primary diagnoses, but it's identifying what type of infection. Is it staph, right? Is it MRSA? Is it, E. coli? What is it that the patient has? Those will be the A and B codes, and it needs to be identified. There is a code for having not identified it yet, an unspecified, but if you're going to be put in the inpatient, they'll do cultures and stuff, and they'll find out what it is. So by discharge, you'll know. Also, pay attention, like I mentioned before, during labor and delivery, following an immunization. These are all times that people can get an infection, and they'll be listed with the code. They'll say, hey, heads up. Are any of these applicable? Because you're going to code in addition or code first. They'll tell you what to do, that part of the guidelines. Now, let's get into some of the verbiage. Sepsis is defined as SIRS due to an infection. So kind of synonymous there, right? As we scroll down, you're going to see some other definitions. If you have an organism, right, and it's described by your ICD manual, Streptococcus is the most common that causes a reaction. There's group A, group B, pneumoniae, pneumococcal, which is what that is. Then there's group C and G and D, intercoccal sepsis, and that would be A41.81. You might write that down, jump out and do a little research on that code. Then it goes on to talk about staphylococcus. Don't get streptococcus and staphylococcus confused, but one is strep and one is staph. Okay, that's pretty common. You can have S. Staphylococcus X aureus. You can have the one that is responsible for MRSA, and again, we'll get that identified eventually. It may not be right away. Methicillin susceptible versus methicillin resistant. Pay attention to that. And then if you have confirmed Staphylococcus strains, you're going to use the code A41.1. And again, these are not primary codes. They're not first listed codes. Then there is Haemophilus influenza and E. coli, Pseudomonas, and Sericea. So again, go out and if you don't know these terms, do a little light reading, Google them and find out. So let's look at a patient. These are your possibilities. You could have pneumococcal pneumonia with sepsis. What would be the difference in coding pneumococcal pneumonia with septic shock and pneumococcal pneumonia with severe sepsis? And again, remember the primary one, like 35%, is lung related. And so I picked pneumococcal pneumonia. So we've got sepsis, septic shock, and severe sepsis. I didn't actually go pull the codes for you. I'm just going to describe how you're going to find the codes, right? We use it as a launching point. Could have coded all this out as an example, but honestly, we do have, even on our YouTube channel, but in our CCO club, lots and lots of education on sepsis and examples that you can look at. So severe sepsis, what does that mean? It's SIRS due to an infection, right? We've already talked about sepsis and SIRS, that progresses to organ dysfunction. So you can't code severe sepsis unless you have an organ dysfunction. A lot of times it hits the kidneys, could be respiratory distress, or it could be something to do with the skin, our largest organ, right? But that's the key term. It can't be severe sepsis unless there's an organ dysfunction. Now, not only do we have guidelines and protocols and stuff when the way we code sepsis, our providers have protocols and guidelines on the way that they document sepsis. So all of this information will be in the documentation. They're trained to do this. They're not trained to code, but they are trained to document, especially for things like sepsis. Now, what about septic shock? Circulatory failure usually is what septic shock is associated with. So if you have a patient that has severe sepsis and then they have circulatory failure, so that's the vascular system, right? The circulatory vascular system. We're not just talking about the heart cardiologically, but the vascular system, the vessels. So septic shock meets the definition for severe sepsis. Okay, and it causes septic shock would follow coding sequencing guidelines for severe sepsis. In other words, if the patient goes into some type of vascular distress, that would be severe sepsis. Now, the information that I pulled from this was actually from the HEMA, and it was quite old, but the information hasn't changed except for 785.52. Some of you guys may remember that. That's an ICD-9 code. So congratulations to the old timers that know ICD and looked at that and said, I know what that means. I failed to correct that for you, but I didn't in the next paragraph where I put septic shock cases you're going to be coded to R65.21. So whenever you have septic shock, and it indicates the presence of severe sepsis, it's not necessary for the provider to document both severe sepsis and septic shock, because it's not synonymous per se, but they're saying you don't have to code both severe sepsis and septic shock. If a person has severe sepsis and they go into septic shock, that's severe sepsis. So you can use R65.21. Okay, and the 785.52 is severe sepsis, but I used to have that memorized in ICD-10, but I don't think I would tell you right. So I'm not going to make myself sound stupid and give you the code, because I'll probably tell you wrong. I think that's it on that information. Great launching point for you to do a little bit of research. We have tons of fabulous stuff that will help you with learning how to code sepsis, and it'll be on almost all of your credentialing exams. You'll be tested on sepsis, because it's critical that we get it right for statistical purposes. Very critical.
Do you need more medical certification and business training? Learn more at www.cco.us.